Hello and welcome to Health Matters. We're so glad you could join us. I am Mary Alale Yusuf. According to the World Cancer Research Fund, prostate cancer is the second most commonly occurring type of cancer amongst men and the fourth most common type overall. There were 1.3 million new cases in 2018, and in 2012, there were estimated to have been 1.1 million men diagnosed with prostate cancer globally, close to 70% of them in the developed world or high-income countries. The prostate is a small gland which sits low in the pelvis, below the bladder, and surrounds the urethra. It is part of the male reproductive system. My guest is from the oncology department at the Lagos State University Teaching Hospital. He is Dr. Ademola Oyekon. You're welcome to the show, sir.
Thank you.
If one could tell what the symptoms were, it might be easier. Do we have symptoms for this?
Yes, for prostate cancer, there are symptoms, but majority of the people that have prostate cancer are asymptomatic, meaning that they might not have those symptoms. And some of them are actually picked while they are on screening, either by digital rectal examination, or probably they went for some radiological investigations. But majorly the symptoms that people with prostate cancer may present with, we usually tag them as prostatism because of the effect of the swelling of the gland along the path of the urethra. It may cause some narrowing. So those symptoms might be in terms of frequency of urination, urgency, dribbling while urinating, or intermittent urination. Intermittent, when the person is urinating, it stops.
Everything doesn't come out.
Yes.
Then they have to go back again.
Yes. Then it can even be pain while urinating. Some may...
Are these early symptoms? When they do occur, do they sometimes happen early?
Yes, they do. Those are the early symptoms. When it begins to get complicated is when the person begins to notice probably blood in the urine, blood in the stool, or pain at the back, as the case may be.
How early can a case be picked up?
How early? In terms of age, or
in terms of age, yes.
In terms of age, we usually advocate that people above 50 years, men above 50 years, should go for screening, because at that age, they might not have the symptoms. But the screening involves checking the serum prostate specific antigen, that's a PSA, and then doing a digital rectal examination by a trained medical officer.
So men are not encouraged to check or go for prostate screening before 50?
Yes. Now, that is a yes with a clause, because for people that have a family history of prostate cancer, especially when the relative has a prostate cancer at age less than 70 or 65, as the case may be. And if he has one or more persons, would tell them to go for prostate cancer screening early, 40 to 45.
Okay.
Yes.
That is because there's a risk already.
Yes, there's a family history.
What do they call that? A first-generation relative who had it.
Yes.
Are there risk factors connected to having prostate cancer?
Yes, there are quite a number of them. Some are modifiable and some are not modifiable. The one I mentioned is the age. It is found out, yes, it is modifiable. It is found out that people from 40 to 59 find out that 1 in 35 men would have will come down with prostate cancer. Then from 60 to 69, 1 in 15 men. and from 70 and above, 1 in 8. So you see that as the age is increasing,
the incidence is reducing.
The risk of having prostate cancer is increasing. 1 in 35.
Okay, yeah, 1 in 8 is a lot more.
Yes,
okay,
1 in 8
that's
is
true.
a lot more. So the risk of coming down with prostate cancer is increasing with age. Then another thing is the race. It is found out that among the Eastern Europe and Western Europe, the prostate cancer incidence is higher compared to Asia.
Okay.
America stands in between. Then even in America, black Americans are said to have a higher incidence of prostate cancer compared to their white counterparts.
So I'm actually
down to,
curious about Nigeria,
yes,
about Africa, because of what you said,
yes,
about African
Now,
Americans.
coming down to Nigeria, the incidence is about 127 in 100,000 men.
How does that play against 1 in 8, 1 in 14?
Yes, 127. That means for every 100 men, 100,000 men, 127 out of them would have a prostate cancer. Yes.
So what does that say about how frequent it is?
It has a higher...
Compared to other nations.
Yes. Compared to other nations, it's in between, but, when we look at the population of a country, it's higher. It's high compared to...
You have more occurrences because of the large population.
Yes.
That's always a problem, comparing when populations are so different.
Yes, then the other risk factors are higher BMI would actually increase the risk. Then it is also found out that amongst the black Africans, amongst the blacks, the testosterone concentration, that's the hormone that's produced by the testes, is higher in blacks. The concentration, and the hormone is what stimulates the growth of the prostate gland. So if there's a cancer, it also stimulates
the growth of the cancer, likewise.
Yes. So that's another thing. Then diet. High fat diet has actually been implicated. So we encourage people to, have increase the fiber content in their meals. Then, it's a little bit controversial. The plant diet, which is common in Asia, it's said to be protective, but there are not much studies to actually support that.
To make it cast in iron.
Yes. Then micronutrients are also found to be protective.
Remind us again where we get micronutrients from.
Micronutrients are from fruits and vegetables. And we encourage people, men above 50, to be taking calcium and vitamin D, because there are studies that are ongoing that actually supports that it has a way of protecting.
So there is something that one can do to help oneself. But if somebody does come down with prostate cancer, how do you treat?
Yes, to treat prostate cancer means that you have to first be sure that it is prostate cancer, because there is also a benign enlargement of the prostate that we call benign prostatic hyperplasia. And what makes it different from cancer of the prostate is the fact that it is non-cancerous. It's a kind of growth in the prostate, but it is non-cancerous. It is not malignant. So to make a diagnosis, we have to do a biopsy. And there are preliminary investigations that will be done prior to that. But biopsy is very important. And with biopsy, you'll be able to know the kind of prostate cancer it is. We call it histology, histologic type. And we'll also be able to grade it.
There are different types of prostate cancer?
Yes. Yes, because in the prostate gland itself, there are 3 different kinds of cells. There's a fibrous, there's a glandular, and the muscular.
Okay.
So the cancer could actually arise from any of those. But the commonest is the glandular. That's the adenocarcinoma. And apart from checking the histologic type, we also want to look at the the grade. That gives us an idea of how aggressive this cancer is going to.
And that would inform the method of treatment.
Yes, it will inform the method of treatment.
So the treatment isn't always, let's just take out the prostate.
No, it is not just always.
What other things do you do?
The other modalities, apart from doing surgery, which is commonly known as prostatectomy, can also do radiotherapy, as a case may be. We also use androgen deprivation therapy. If you remember, it said that
reduce the testosterone.
Yes, we are going to get hormones that will suppress the effect of testosterone on the prostate. So the other modalities will now also depend on the performance status of the patient. Is this patient strong enough to take treatment? What are the concerns of the patient? What's the most important thing? And what are the other comorbidities that this person may have that may actually make the treatment difficult? So we'll weigh that. For some patients that their life expectancy is less than 10 years, we can just observe them. They are frail. They have a life expectancy of less than 10 years. We'll observe them. If you have any symptom, we treat the symptom. We call it watchful waiting.
Okay.
Yes.
What if you have a 40-year-old man?
Yes.
With
A
prostate cancer who
40-year-old
is
man.
eager to have children.
A 40-year-old man with prostate cancer who is eager to have treatment. We have to look at
children.
To have children. For that kind of person, we have to consider their concerns. We also have to consider the stage of the cancer. Prostate cancer in the young, as the ones that have been observed, have been found to be very aggressive. So it's not something that the person will go for screening and you pick. Most likely the patient will come down with symptoms already before. But let's say maybe in an hypothetical situation where the person has a low-grade disease and he wants children, we can actually offer the patient prostatectomy. The prostatectomy actually has a way of affecting the
procreative abilities, right?
Yes, that's in terms of cause some levels of erectile dysfunction, but it's not a common complication. Maybe it's about 15 to 20%.
Oh, okay.
So maybe out of 100 that goes for the surgery, maybe about 15 or 20 of them would actually have that. And in the best hands, you are likely to have better results. So the person can still procreate. But when you look at it in our environment, if a person with prostate cancer at that age comes down with symptoms, is most likely going to be aggressive, and what you may be able to offer that patient is palliative. We call it palliative treatment, meaning we just manage and nurse symptoms, make the patient more comfortable as much as we can.
Studies say that if it's detected early enough, it's sometimes 100%, almost 100% survivable. But if people are not being encouraged to check if they have it, how do they detect it early? Especially since you have the types that don't come with symptoms.
Yes, it all starts with screening. You want to screen the patient for prostate cancer using the PSA. And what would encourage basically is for people above, from 50 years and above, to go for that screening yearly. Then people with family history of prostate cancer from 45, maybe one family history, one first degree relative. If they have more than 1 degree relative with prostate cancer, maybe from 40. But what they do...
Let me hold you there. We'll come back and continue this, but we need to go on a short break. Stay with us, and we'll see you on the other side. Welcome back. Please tweet at CTV_Mary A or call 0805 468-3914. That's 0805-468-3914 for questions on prostate cancer while we continue with the topic. You were talking about the age that people should go for screening.
Yes.
And I'm hearing you saying 40 as the youngest age.
Yes.
Does that mean that we can safely say that prostate cancer is a really old age disease?
Yes.
Anybody below 40 shouldn't be bothered about it.
No.
But do they get early onset types though?
Yeah, there are outliers. Yeah.
Okay.
Just those exceptions that you just see once in maybe 10 or 15 years. It's possible. In medicine, we don't rule out anything. Anything is possible.
So what are the complications of prostate cancer? Assuming somebody has it and doesn't go for treatment and is just hoping on, one day I'll feel better, it will get better, it will go.
Well, actually, I wouldn't use the word complication. I would rather say the progression of the disease.
Okay.
Because it will spread and maybe from the primary sites, the prostate, it can spread anteriorly to the bladder, superiorly to the bladder, anteriorly or posteriorly to the rectum, and even to the side wall. So it can spread to the bone. Most commonly it spreads to the bone, and that's the reason why you see maybe an elderly person, after a trivial fall, he has a fracture. We call it pathological fracture. Okay. And those are things that actually reduces the chances of survival of the patient and reduce the lifespan of the patient, because when comorbidities are setting in...
Let me just cut you there briefly while we take a call. Hello? Hello?
Hello, good afternoon.
Good afternoon. What's your question?
My question is about that prostate cancer. And I've just opened my TV now and saw what is happening. Please, I want to ask, because my father had such a problem before he died. And I want to know whether that problem is it more that it will go to his children. Possible, because my father had the operation at Oka before he died at the safety hospital.
You want to know if...
About that thing was a generational...
okay, whether you can pass it on to your child. Whether it's hereditary.
Yeah.
Okay.
Yeah.
Thank you very much. The doctor will attend to that. So, is it something that one inherits from his father?
Yes, it is. Some of the risk factors are actually genetic mutations that may occur in some genes, like the human prostate cancer gene 1 or BRCA gene 2 is also implicated. There are other genes that are also found to be implicated in prostate cancer, like the retinoblastoma gene and etc. So it could be passed to the next generation. And like I said earlier, if there's a family history in first-degree relative,
you go for an earlier screening, 40 to 45.
If you have more than one person's having prostate cancer in that same first-degree relative, you should go for a screening.
Okay, let's backtrack a bit to prostatic hypoplasia. I'll bring a question about that, but I believe we're getting a call. Hello? Hello?
Yeah, hello.
Welcome to the show. What's your question?
Yes, my name is Francis. Yes, I'm calling from Abuja.
Okay. You need to put your TV off, sir. Put your TV off.
Okay. Hello?
Hello?
Yes, I once went for a test, and they said I had benign prostate enlargement.
Okay.
So the doctor is talking of cancer all through. I don't know whether... And when I also went back to another doctor to find out what to confirm what they said, the doctor checked and placed me on a drug that mine is not that bad to go for an operation.
Okay.
So for a very long time now, I've been taking the drugs they asked me to take. And even though I urinate so frequently, but it's not bringing out the blood or the pain, the doctor.
Okay, thank you very much. So we'll ask the doctor to address that as well. Thank you so much for calling. Okay. You know, we're just about to go to that benign hyperplasia. Yes. He's having symptoms that look like prostate cancer, but they said it's benign. How do you treat a benign enlargement? For benign enlargement, like I said earlier, it is not cancerous enlargement of a prostate. When it's cancerous, cancerous means it is not controlled. Mm-hmm. It persists and even goes beyond boundaries and spreads to other parts of your body. But then how do you treat this one? So because there's discomfort. Benign prostate hyperplasia, they may present the same way. And that's the reason why I mentioned the fact that both of them can narrow the urethral opening. So they may present the same way. It doesn't mean that, and that's the reason why we advise that they go and do their check, the PSA and the DRE, and possibly biopsy, and be sure that it's just benign prostatic hyperplasia. And in this case, if you want to treat, depends on how bad the symptoms are. There are drugs that we use for that enlargement. There's one we call tamsulosin. We use it to actually, to reduce the rate of growth of that, the prostate gland. And it's a 5-alpha reductase inhibitor. So that's what we use. But in case where it is persistent and is for patients that it's disturbing for the patient, then the doctor can also speak with the person. Maybe there's a surgical perspective to it, and probably if they can remove the prostate. Just for him to be comfortable. Yes, just for him to be comfortable. But it does not now affect his ability to procreate then? No, it doesn't. I believe we're getting a call. Hello?
Hello?
Hello? What's your question? Good afternoon.
The question is, why is it that most people who have been operated on this prostate cancer issue never survive? Even if today you have hope of survival, the next thing you hear is they die. Why is it that they've not been surviving, those who were operated upon?
Thank you so much for that question. Doctor, is that true, and why? Yeah, it is true, because in this part of the world, a lot of people are not educated, and even the people that are educated are not literate health-wise. So for people in this part of the world, like 80% of the people that come down with prostate cancer come in late stages. That's based on, that's why they die shortly after. So you may not be able to, when he talks in terms of surgery, the surgery that may be offered to those kind of people may be just orchiectomy, where the testicles are removed. That may be the surgery. That's to starve the prostate gland. That's the aim. Okay. So that may be the surgery. So let's go in 30 seconds. We're out of time. Yeah. What can a man do to prevent himself having prostate cancer? Behavior. 30 seconds. Yeah, I think if we look at the risk factors and we begin to address them, we have mentioned the ones that are modifiable and the ones that are not modifiable. The ones that are modifiable in terms of the BMI, lose weight, do active exercise, your diet, high and go for fiber screening, diet, I suppose. Go for screening once you're 50. Calcium and vitamin D supplements. I think that was very, very good. Thank you so much. Thank you so much for coming to the show. Thank you. And thank you for being with us. Thank you for all those calls. I hope you've learned something today. Enjoy the rest of your day. I am Mary Alale Yusuf.